Hossein, very good to have you here. So in the prostate cancer space, Hossein, you're very aware, and we know that PDE5 inhibitors play a very large role in patients post-prostatectomy, radiation, etc. How do those drugs work?
So normally, John, as you know, the cascade is a very intricate cascade of nitric oxide release, leading to guanylate cyclase, making cyclic GMP, which then goes on through protein kinases to work on ionic channels and the contractile mechanism to actually lead to vasodilation of the vascular system. So that's normally how PDE5s work. And then the PDE5 inhibitors basically block the enzyme. So by blocking the enzyme that breaks down the cyclic GMP, they allow the vasodilation to persist and for the erection, therefore, to happen.
And I suppose then that if you don't have a lot of nitric oxide, then these pills cannot work well.
Correct, which is part of the challenge you and I face when we treat our patients with prostate cancer, because that mechanism can be disrupted in those patients.
And when you see a patient, let's say post-prostatectomy, how do you choose which PDE5 inhibitor you're going to use?
You know, I talk to them about the nuances and the differences between them. We know, for example, that tadalafil, commercially Cialis, has a longer half-life, about 17 hours. So patients who are perhaps more interested in the duration of action, or if you want to say spontaneity, they may want to go for that option. Whereas sildenafil, it's a more finite set time, same with Stendra, who is that Vanafil that has a faster half-life. And for certain patients, they don't necessarily want the longer acting effect. They want to say, I take this drug, I wait a certain period, and then I want to know that it's working for me. So I discuss it with them, and then I tailor it to each individual patient.
And if you're using a PDE5 inhibitor in, let's say, a rehabilitation program, post-prostatectomy or post-radiation, do you have a preference of which medication you're using?
The past year and a half or two, I have moved a little bit toward daily Cialis, daily tadalafil. I started before surgery. Being at NYU now, I pretty much see all the, most at least, of the pre-prostatectomy patients. I start them on this regimen of daily Cialis beforehand, and then after the catheter comes out, I do the updosing. In other words, I tell them to take a pill a day and then a higher dose a few times a week. So that's been my preference. But of course, there are patients, for example, who may have a side effect specific to tadalafil, in which case I would do low-dose sildenafil for them.
That's an interesting point. So what side effects do you typically counsel patients about?
So first and foremost, I always remember, I mean, for us, we are so used to this, we prescribe these medications all the time. But I review the basics, contraindications with nitrates. If you're being treated for pulmonary hypertension, Briosio, it's a medication you and I never prescribe, but at least I'm aware that is a patient on it or not. So I tell them about that. If they have certain conditions, retinitis pigmentosa, things like that, I use caution in those cases. If they're on alpha blockers for whatever reason, I tell them about the timing differences. So those are some of the things that I think about. But in terms of the side effects, to answer your question, for example, with tadalafil, one of the things that we do see very frequently, well, not very frequently, but more frequently than with sildenafil, for example, is myalgias. And, less than 5% of patients, but it still can happen. With all of them, vasodilation, flushing, headaches, which can happen, again, in a small percentage, but it's important for them to be aware of. And then, of course, if they're on sildenafil, I tell them about the blue-green vision, which is transient and wears off. But I tell them that in case you experience any visual acuity changes, then you stop the medicine and you talk to us.
Okay. And is there any circumstances in which if somebody, let's say, post-prostatectomy fails one PDE5 inhibitor, you might consider using another?
You know, I actually rely on something you and I discussed, and I think was one of your early works, that if you are using these drugs correctly, there's really very little difference in efficacy. So it really comes down to a side effect. If a patient is bothered by a myalgia, then I will switch them. But if they're, and again, as you know, in this indication, we're doing it mainly for penile rehabilitation. It's not like we're expecting them to have amazing erections with these low doses, but that would be the typical scenario for me.
Okay, and that's exactly what I do.
Yeah, yeah.
So thank you very much for being here today.
Thank you. Pleasure.